So I'm originally from Massachusetts, but I've been in Oregon 22, 23 years now, a long time. I went out there for my residency in family medicine and just loved Oregon, loved the people, loved the geography, and it's a great place to be a family doctor. So I have had a historically good old-fashioned womb-to-tomb practice. Stopped that a few years ago. It's kind of tough to juggle a continuity practice and being a legislator at the same time. But I got really involved with legislative advocacy back in about 2002 when I was really concerned that our legislature didn't understand the importance of providing primary care to all Oregonians, and in particular to rural Oregonians. Although I'm a metro-based physician, I'm on the faculty at the medical school in Oregon. I'm very active with the Oregon Academy of Family Physicians, and we have members obviously all over the state. So got really involved there and ended up in the legislature 2 years ago. So Oregon's a really interesting state. I mean, I think many states have their rural areas, but in Oregon, 80% of our population lives within 15 miles of I-5. That means that we've got 900 square miles that have 80% of our population, and 9,000 square miles that have 80% of our population, and another 87,000 that have the other 20% of our population. We actually have frontier counties in Oregon, which means that the population is less than one person per square mile. And you know, we know about the challenges in rural America, and it's equally true in Oregon. For physicians, it's harder to practice in those areas. The reimbursement's lower, relatively speaking. They can be sort of at the upper end of the education spectrum in that community. They may have concerns about jobs and interesting work for their spouses. They maybe have concerns about the schools for their kids. So it's hard to convince physicians, nurse practitioners, PAs of any specialty to locate in our communities. And you have to have a certain patient population to sustain a practice. Now, for a family physician like me, that's not so bad. With a patient panel of 2,000, I'm doing okay, right? And even though mental illness is really prevalent, and we know that 20% of Americans either have chronic or at least intermittent episodic issues with mental health, but that means that you need a population of more like 5,000 or 6,000 within a reasonable area to be able to support a mental health practice. We've worked really hard to think broadly about what a robust healthcare workforce looks like, to make sure that there are enough providers of lots of different kinds, and that's both physical and mental health, and to my mind, dental as well. I mean, if you don't really take care of the whole thing, I always say I can't manage someone's diabetes if they've got poor oral health, right? And I can't manage someone's diabetes if they don't have stable control of their mental illnesses as well. So we've had real challenges making sure that communities in rural Oregon have adequate access to mental health, and a lot of times the primary care providers end up providing the vast majority of it. And although we're well trained, it's still not always adequate, especially for our more complicated patients, and we can't do ongoing cognitive therapy, the talk therapy that we know is so important, sometimes instead of medication, sometimes in combination with that. So we've got some really exciting initiatives that were started originally by the medical providers, and now the state's gotten really involved with supporting. The most exciting one probably is what we're calling OPAL-K, the Oregon Pediatric Access Line for Kids. And this is a collaboration between the psychiatric staff at the medical school, Oregon Health and Science University in Portland, and the State Pediatric Society and the State Academy of Family Physicians, who are really providing the vast majority of care to kids around the state. And what this does is it allows primary care physicians to just pick up the phone and call. There's always a psychiatrist, a pediatric psychiatrist on call at OHSU, so that any hour of the day or night, a physician from a rural part of our state can pick up the phone and call for an acute problem, and then they can also set up an ongoing relationship with our, you know, so they can do ongoing management. And this is really helpful so that families don't have to travel long distances to get ongoing care for mental illness issues. We're doing some really interesting stuff too with how we credential telemedicine providers. I actually will take credit for this, although this is a sign of why as a legislator you shouldn't fly on airplanes. I was flying and the man who's the physician who's the head of the telemedicine program at OHSU was on the same plane, sat down next to me and said, here's the problem we have. And it turned out that smaller hospitals around the state were requiring physicians to go through the entire credentialing process, down to getting their TB tests redone or retaking their HIPAA training. I can't quite figure out how you transmit TB over Skype, but it's okay. Anyway, so we got legislation through this year. The other physician and I got 2 bills to streamline credentialing through this year and make it a lot easier, and that's going to help us provide not only the kinds of traditional telemedicine services like stroke care or trauma or for real preemie babies, but also psychiatric care to people in rural Oregon, including cognitive therapy, talk therapy over time, and that'll be very, very helpful to us. Telemedicine is really going to offer opportunities to improve the quality of care, improve access to care. It's going to be a great economic development tool too, Josh, which is really exciting. You know, employers want to be sure that their employees are going to have great medical care, and that's how one of the ways they choose where they locate growing businesses. And in Oregon, we've seen the opportunity now to invite some businesses in or encourage them to expand to rural areas because we can offer them better telehealth, better telemedicine services. For telemedicine to work really well, we have to have fully integrated electronic health records. And that means we have to do a lot to support our rural health providers with getting robust electronic health records. And we have to have, this is a place where I think there's a real role for the federal government and something that happened with the Affordable Care Act, to require true interoperability of electronic health record systems, right? I mean, right now, if I write a document in Pages, which is a Mac platform, word processing software, I can choose whether I save it in a Pages format or a Microsoft Office format or whatever, or as a PDF, and that means anybody can open it and read it anywhere. But that's not true. You know, even in the Portland metro area, all 5 major health systems have the same provider, but we can't actually truly import data across. We can see it, which is a huge step in the right direction, but we can't import it. And so the way we're sure that medication is reconciled, the way we're sure that everybody involved in a person's care is, you know, reading from the same sheet of music, is to make sure that our electronic health records are fully integrated. So telemedicine will only work really, really well when we have a robust, fully integrated electronic health record system for every provider.